Okay, let's talk about some non-invasive monitoring. So we're going to get a little bit in depth here with pulse oximetry. I know it's pretty simple, but let's go a little bit in depth here, especially looking at reflective and refractive pulse oximetry, why you'd use one over the other. So let's start with just the basics. Pulse oximetry is pretty inexpensive and non-invasive to look at blood hemoglobin saturations. Well, remember, it doesn't say blood oxygen saturations, it says blood hemoglobin saturations, which easily means if the hemoglobin is dysfunctional, or if the hemoglobin is left shifted, or if the hemoglobin is occupied by another molecule, then it can easily throw off what's actually going on with the patient physiologically. That's why the arterial blood gas is still going to be the gold standard for oxygenation management or oxygenation monitoring. So this cannot replace the AVG for accuracy, no matter how strong these get, unless there's some way to actually look at oxygen on the hemoglobin molecule, then there's no way that it can really overcome that currently. So we're looking at SpO2, so pulse oximetry. So we're looking at how much oxygen in theory, so we're assuming, right? So pulse ox assumes that whatever's on the hemoglobin is oxygen. And so that's what we're looking at here. So how much of the hemoglobin is being taken up by something it's assuming is oxygen. So how much oxygen or whatever it sees on the it does this by photospectrometry. So we'll talk about this a little bit more. Indications for pulse oximetry. We're trying to monitor their oxyhemoglobin. So this says we already know what their hemoglobin is with oxygen. So we've drawn a blood gas. We had a pulse ox on at the same time. We noted that it was pretty accurate with the pulse ox and the blood gas saturations, right? There was pretty good correlation there. And so now we can use it to sort of monitor their trending values there. We also use it to quantify response to therapeutic procedures. So, hey, did I increase your heated high flow nasal cannula from 30 liters a minute to 40 liters a minute? And now I see an increase in pulse oximetry, right? That's a sign that I had a therapeutic response, right? Comply with mandated regulations, especially if they're post-procedure or they're on pain medicines, things like that. They might have to require those patients be on monitoring to include pulse oximetry. Contraindications, the need for ongoing actual measurements of pH, CO2, and PO2. So that's the thing, like if they're requiring to monitor pH, CO2, and PO2, pulse oximetry won't be able to do that. So you cannot replace a blood gas with pulse oximetry, no matter how currently accurate it is, unless something changes in the future, which that would be nice, right? Less sticks in the artery would be nice. Or if they have a dysfunctional hemoglobin, that whole Jerry Springer hemoglobin where they have, where it could be met hemoglobin, it could be sickle cell, it could be you name it. There's a bunch of different types of dysfunctional hemoglobin, carboxy hemoglobin. So you name it, it's not going to be quite as accurate. There are like the rainbows that actually look at co-oximetry on there. So if you look up the Rainbow 7s, I think we actually have one in the lab that actually looks at co-oximetry. Now that's a whole separate thing. But currently, if we need to monitor pH, CO2, and PO2, pulse oximetry is not going to. Precautions, false readings, that's one of the biggest things to look out for. I've seen pulse oxes disconnected from the patient, and they're on the bed rail of the bed, and they're reading a reading. Or they're in the sheets of the bed, and it's reading a reading. It has a reading. So be cognizant. It is a machine, just like any other machine. It has little idiosyncrasies, so you just got to understand that. Does a patient match what's going on with the monitored values? Something I talked about with the radiology students, I looked at the patient, I tell them, hey, if something's going wrong, you hear a machine beeping or alarming or anything like that, you're going to look at the patient first and see what's going on there and then work your way back to the machine. So I'm like, you might be the first one that actually catches that the patient's disconnected from the ventilator. Everybody else might be actually looking at the ventilator or looking at the monitor and not actually looking at the patient. So when something like this is going on, look at the patient. Do they look like what the monitor says is going on, right? So something weird's going on. Look at the patient first, then work your way back, right? So false reading can also in theory cause tissue injury. This is more common in more generationally advanced individuals and or really small preemies where they can get some sort of tissue injury or necrosis if it's too tight. Right, just like with anything else, they could have skin issues and things like that. Assessment of needs. So direct measurement is not readily available. Well, then we can use pulse oximetry. There was an article by Respiratory Care Journal that came out a couple years ago. I want to say it's 2016 or 2000, yeah, probably around 2016 in Respiratory Care Journal that looked at pulse oximetry and accuracy, and one of the most popular groups that patient populations that it was most inaccurate in was COPD patients, which is the exact population you would want pulse oximetry for, so they can monitor their saturations when they're ambulating and when they're walking around the block with their little dog, right? So that's something that we have to be aware of because it's perfusion dependent. If they have arteriosclerosis or they have poor perfusion, renewal, so that they have poor perfusion to their digits, right, then are they going to be able to get an accurate reading so that we can be reliable and make changes upon those readings? That's something we need to look at. So continuous prolonged measurements, something that we can use it for, however, it will not replace arterial blood gas with accuracy currently. When acid-base status is not needed, of course we can use it for sure. That's something that we can easily look at and be like, okay, we can trend it there. In the pediatric ICU is a very classic case of this. It's rare that we put art lines in kids as well. So usually they'll have a central line, and so we'll draw blood gas for pH and CO2 off of the central line. So we'll draw VBGs if needed. But with kids, especially, they don't usually have any vascular issues. If they don't have any vascular issues, I should say, which is rare if they do. But if they don't, then they should have good perfusion, therefore a good correlation with oxygen monitoring here. Unless they had something like carbon monoxide poisoning or something like that, then we'd have to change it. Or if they were on a lot of nitric, then we'd still have to draw arterial blood gas to look at methemoglobin or co-oximetry, right? So co-oximetry would be one of your big things you'd have to be concerned about here. Assessment of outcome, it should reflect their condition. So if you're looking at a pulse ox and it's hardly any waveform and it's reading 70% and the patient is pink, right? Their extremities are well perfused, they're talking to you, right? They're not working hard to breathe. Odds are it's probably a bad pulse ox probe or something like that going on, or signal, right? There could be motion artifact. So this is something where if it looks weird, look at your patient first. Does this match their clinical condition, right? There's no need to call a code because the monitor reads one thing, but the patient's actually talking and speaking fine, right? Assessment and outcome, documentation of the results, and intervention. So that's one of the things we'll look at, like with NEBS, pre and post, so on and so on. I always ran most of my NEBS on room air, but that's a whole separate thing, and we could always talk about that when we get back and we're not on YouTube. Pulse oximetry. Frequency of pulse oximetry is determined by the clinical status of the patient. It could be just with vital signs, right? Remember, pulse ox is technically, I think, your 6th vital sign. So it's not sort of required. Some hospitals do require it, so that's more of a facility type thing. Clinical status of the patient. If they're very, very sick, they're on ICU, in ICU on a ventilator, they're on cardiac monitoring, they're on respiratory fatigue, respiratory failure, cardiac fatigue, cardiac failure, right? They might need that continuous pulse oximetry. So this is going to have to be based upon the needs of the patient. Hemodynamic compromise, right? The sicker they are, the more likely they are to need continuous. The healthier they are, the less likely. So if I had a total knee replacement, so let's give you a scenario. If I had a total knee replacement and I'm up in the orthopedics unit and I'm on a lot of pain medicine, would I be indicated for continuous pulse oximetry? Well, some could argue, or some could question that, yes, I would be, especially if I'm on pain management, because that could easily alter my drive to breathe and therefore alter my oxygenation. If it was my way in the hospital, it would be more end-tidal management or end-tidal monitoring than pulse oximetry, because the end-tidal will actually be give you a lot sooner, a lot better signal of when the patient's going into respiratory fatigue versus pulse oximetry. We'll do brain death protocols for patients that we think are brain dead. We'll take them off the ventilator and we'll just put oxygen on connected to their endotracheal tube, and we'll wait 10 minutes. And what we'll do is we'll draw blood gas before we do it, and then we'll draw blood gas at 10 minutes. And then what we'll see is if their CO2 rose 10 millimeters of mercury, then that's a sign that it's one of the many signs that they're brain dead. So it's not the only test that we'll do, but their oxygen levels will be fine. Their oxygen levels won't drop during the whole thing. So that person hasn't been breathing for 10 minutes and they've gotten to more acidic state, and yet their pulse ox hasn't changed. So which one do you think is going to be more accurate? CO2 levels will catch hypoventilation way before pulse oximetry. So we'll get into that when we get to the CO2 lecture here. So determined by the status of the patient, how sick they are overall. Instrumentation, we're looking at using light waves, so it uses nanometers, and then I think we talked about this in pulmonary EMP, uses volume changes. Light detects volume changes in the pulsatile blood flow, so it uses infrared light to either reflect or refract the pulse ox down to the site. So you'll have the LED transmit light into or through the tissue. Usually they're two-sided. That's what you see with the finger pulse oxes, and that's what you see here is the two-sided light source, where the light's on one side and the detector's on the other side. So it'll transmit it through the tissue to the other side, and that's traditionally what's used. But there's also other sources here, and that's what I have a picture of here on this next page. There's reflective pulse oximetry. So reflective pulse oximetry says, hey, you have very, very poor perfusion. And I know there's a finger here in this top graph, but look at this bottom graph of this person here. He looks like he's a villain from some sort of thing, like Magneto, which he wasn't. But anyway, we're moving on here. So the pulse ox here is a forehead pulse ox. So it's usually right over the eyebrow. And there's lots of good surface perfusion in the scalp. If you've ever seen a scalp bleed or scalp lacerations, you know they bleed quite a bit. So there's a lot of blood vessels in the scalp area, and so we can reflect pulse oximetry pretty darn accurately. So if someone has very, very low blood pressure, or let's say someone's on a vasopressor that vasoconstricts, so they're on vasopressin, norepinephrine, you name it, then we can put them on, or they're hemodynamically low, like let's say they're in shock, or they're in a massive blood loss situation, or we're doing compressions and we want to figure out pulse ox during compressions, right? So anything that has low hemodynamics. You can use the forehead reflective, so this is what you see down here on this guy. You can put this forehead probe on and it just goes right over the eyebrow and it will reflect the blood oxygen levels back to its own self. So that's the reflection one you see on the right side. So that's what that guy's wearing. So anytime in the emergency department we had a patient come in with poor hemodynamics, or we're in the ICU and we have a patient with poor hemodynamics, we'd put the reflective pulse ox on because it was the most accurate way to get a good value. If they're vasoconstricted in their fingers and their toes and they're cold and they're hypothermic, which one's going to be more accurate? The one on their finger or the one on their forehead, right? So that's what we're looking at here, is that reflective one could actually be more accurate with hemodynamically compromised patients. So low blood pressure, think reflective pulse oximetry. Low blood pressure or vasoconstricted extremities, or they're on pressors, we might get a way better accuracy with a reflective pulse ox or forehead probe than we would with a finger probe that's a transmission related. So please understand those differences, especially in critical care medicine and in adult medicine. That reflective probe is going to be awesome for you. Now understand, some people will take these transmission sticker probes and just pull them flat and put them on the forehead. Understand that where the light is transmitting, and when you take this and unfold it for one of those sticker finger probes, and you unfold it to put it on their head, that now the light source and the the receiving parts are now way far apart. They're not close together. So now they're very, very far apart when you do that. So you might get a signal. The question I have is, what is the accuracy of the signal using the finger sticker and placing it on the forehead? So your accuracy may not be near what it is with an actual designed reflective pulse ox. So you'll see the people do the stickers all the time, lay them flat, put them on the head, be like, oh, I got a good signal. And I'm like, well, that's something, right? So just be very aware. I would question the accuracy of those because the light source and the receiving part are so far apart that it may not be picking up accurately what's going on, because now the LEDs have to travel that much further before it's received compared to one where they're close together. Their proximity is a lot more optimal for better accuracy with the LED and the reflection. So they have to be close together. The closer they are together, the more accurate that signal is going to be. That's why I'm not a big fan of the finger probe that's stretched out across the forehead. Pulse oximetry. The signal that they get is filtered and amplified and put onto the machine, and that's where we get the display. I put one of the older signals here just for nostalgia's sake. I love the old looking signals here, classic green look. This patient here, you see there, you could actually set their alarms here too. The low saturation alarm 86%. So this might be an emphysema patient, right? In a pulse ox level of heart rate level of 50. Right, so this person might just run a lower level. So just those are the alarm levels in there. So it'll take the signal, it'll display it for us. And this is the nanometer, so this is the reflection that we're seeing. So the baseline and pulsatile flow, it's using red and infrared, so 660 nanometers and 910 nanometers, and it's looking at a bound versus unbound hemoglobin. And that's how the basic pulse ox works. So your basic finger pulse ox works this way. Now, over the Massimos have more advanced technology that also looks at hemoglobin concentrations and things like that. We won't go into that here, but there is better technology out there than what the basic ones are. Most people are still running these basic ones out there. All right, accuracy with the pulse ox should be within 3 to 5% of the ABGs. So if your ABG is reading 97% saturated on the ABG, so SaO2, and then your SpO2, which is the pulse ox, is reading 97%, then that's within 3 to 5% of accuracy. So they're correlating well, so that's a good sign. If it's not, then that's where we're having issues with trying to figure out why their saturation would be so different. So is there an issue with, are they on vasopressors? Are they cold? Is there extra light in the room? Things like that that could alter the accuracy of the pulse ox we have to be aware of. As their saturation falls, so will accuracy. So let's say a patient's in severe ARDS, and their saturations are anywhere between 85 to 88%, which is okay, right? They're right shifted. We want them to sort of be in that range, right? We want to avoid the oxidative injury. We have a lot of other things going on. We want to remove a lot of CO2, so we're not trying to get too much oxyhemoglobin. So this is a whole separate thing. So as the saturation falls, right? So as their actual saturation falls, the accuracy will. So let's say they're running at 85%. Well, the accuracy on the pulse ox will not nearly be as accurate, because as the pulse ox, as the level of bound hemoglobin decreases, it's going to have a harder time getting accuracy in a percentile range. So they're not considered accurate at saturations below 70%. So if you walk into a room, the nurse says, hey, the pulse ox is at 40%, just understand their oxygen level could be low, right? I'm not going to actually chart or document, hey, their saturation is at 40%. That's not something that I can accurately represent. You could chart that you've seen it there, but it is not considered accurate below 70% currently. So that's something that just be aware of, because the limitation of the technology is such that as the saturation of hemoglobin decreases, the less accurate these devices are. That's just the technology limitation there. So the lower the saturation reading, the less likely the accuracy is correct. So when you see a pulse ox less than 70%, just understand their oxygen levels are low. But the only way to truly tell how saturated they are would be an ABG at that point. And at that point, an ABG could be indicated as long as other people were providing appropriate therapeutic intervention. You could draw an ABG there, right? But appropriately, you'd want to take intervention if procedure. Make sure you follow the manufacturer's protocol. I know Massimo had a different one than Covidian. So these are something that you just got to be aware of. And it's usually on the package of the pulse ox. I know, reading the package, novel idea. But the other thing is you don't want to mix components. You want to put a Covidian pulse ox and a Massimo pulse ox. And a lot of times they won't let you do that to those manufacturers. So it's just something to be aware of. That mixing components, if you are somehow able to get a signal, especially with the older machines, then that may not be the optimal way. There might not be a proper signal transmission, so I would not trust it as much as if you use the right sensor for the right machine. Sensor should be the right size. You're usually not going to use a neonate sensor that's supposed to go on a neonate's finger or toe or heel. You're not going to use that on the adult finger. It's not going to be nearly as accurate there. So make sure you're using the right sensor size. And they have all different sizes. Confirm a good signal, right? Allow time for it to read a signal and come out. One of my finger pulse oxes that I have, it takes about a good minute or so before it reads a good accurate heart rate. So it has to give it some time before it calculates, before its internal algorithm sort of reads that accurate heart rate. It looks at pulsatile flow, and then it recalculates, and then after a minute, okay, this is really what their heart rate is. So I'll put it on, and everybody's heart rate says like 50 to start off with. And then, oh, okay, now it's 83. Okay. So just give it time when you put a pulse ox on. Give it time. Don't trust that first reading. You might have to wait for the algorithm to sort of read out. So confirm a good signal. Hopefully there's waveforms on all the pulse oxes that you're reading. Most pulse oxes nowadays will have the waveforms, so you can sort of see how strong of a signal it's getting. If you got almost no signal and it's getting a very poor reading, I would not trust it. So look at the waveforms, look at the pulse, look at the signal, and sort of see where you're at. Set the low saturation around 88% or 92%, depending on what patient population you're working with. I know ICUs, if we're running severe ARDS and permissive hypercapnia patients, will run their pulse ox at 85%. So you have to sort of know what your SAT goals are for that patient that you're taking care of. No matter if they're in the NICU, PICU, or ICU, you need to be in good communication with the SAT goals as far as everything goes with your patient. Validate the baseline with an ABG. In other words, correlate it. If they're not correlated, if they're not within 3 to 5%, why? Is the patient on pressors? Is there clotting? Is there a bunch of issues with arteriosclerosis? Is there something that's causing that decreased accuracy? Something for you to look at. Make sure if you're using the reusable pulse oxes or the finger pulse oxes, you're cleaning it in between patients. I guarantee you that guys have all followed a RT out there or a different provider out there that has not wiped down their equipment in between use on patients. Please just do that. Most rooms, we had a lot of rooms that had their where the patient had their own pulse oxes in the room. They had their own vital sign machine in the room. So I would just use theirs. I had mine if I needed it, but most of the time I just use theirs that are in the room. Inspect the probe site frequently if they're on continuous pulse oximetry. So that's something where we just got to make sure we're not causing pressure, too much pressure from it being on the site. We'll change it from time to time. That's just something just to make sure, and that avoids also like things building up underneath it. It's just pretty nasty if you don't change the site. Right, never act on saturation readings alone. Remember, your saturation readings are poor. What's the first thing you do? You look at your patient. and then work your way back from there. So always look at your patient first. Never treat a pulse ox signal without looking at your patient and treating them. If they're talking to you and they're just waving at a friend over there, that's probably why their signal's bad. You work in pediatrics, you'll see pulse ox signals that are super bad looking. You go into the room, the kid's jumping around in their little crib, right? So it's something to be aware of. So be careful with the readings. You got to have a little bit of understanding of, does this fit the rest of their clinical condition? Documentation, of course, if we're doing pulse ox checks or 6-minute walk test or anything like that where we have to do pulse oximetry documentation. Obviously, date and time, what position, were they walking, where was it, were they active, were they ambulating, or were they resting, right? How much oxygen were they on, what type of pulse ox, does it correlate to the blood gas, how stable is the reading, good waveform, did the patient, what was the patient's clinical appearance with it, right? Those are great things to document, because if I document their clinical appearance was great, their blood gas was great, but their pulse ox was poor because they were on a massive amount of vasopressors, right? And so we weren't getting a lot of good perfusion to their fingers. Well, that's something I could document and then talk with the care team about a reflective on like the forehead. So that's something you should be looking at. Document the heart rate on the pulse ox to manual palpation. So that's like what I said with one of my finger pulse oxes, is I would never document the first heart rate I've seen, because the algorithm in there, it's got to have time before it gets that accuracy there. So give it some time. But if the heart rate looks odd compared, then you're just going to want to palpate the heart rate or auscultate the heart rate. I worked a lot in pediatrics as well as the adults. In the pediatric side of things, you usually auscultate the heart rate with those little guys, especially neonates. And so if the pulse ox is reading a heart rate of, let's say, 80, and you're listening to this person's lungs, and sure enough there's a heart there, and you're listening to the heart and it sounds like it's going a lot faster, then odds are something's wrong with that perfusion at the side or something. So that's something pretty easy. You can either palpate and or auscultate. That's still going to be more accurate than looking at the pulse ox value. And that's one way to actually tell how accurate your pulse ox is by actually palpating or auscultating the heart rate or comparing it to the EKG. So if they're on a continuous EKG monitor, right? So they're in the ICU and they're on a 3-lead, right? You can actually look at the heart rate on the EKG and compare the heart rate on the EKG to the heart rate on the pulse ox and sort of see how accurate your pulse ox is picking up the heart rate. If the heart rate and the EKG heart rate on the pulse ox and the EKG heart rate do not correlate, then it's most likely, unless there's something wrong with your EKG leads, it's most likely the pulse ox that's not picking up good perfusion. So that's something you need to be aware of and ready for in critical care medicine, right? So I'm going to compare their EKG to the pulse ox heart rate. So if the two heart rates aren't pretty in sync with each other, then I know there's probably an issue with the accuracy of my pulse ox. So that's how you check a pulse ox accuracy at the bedside, is you check an EKG heart rate with the pulse ox heart rate. Now Biomed actually has an artificial finger. It's pretty funny. Artificial finger that you can put a pulse ox on, and it has a known value, and you can actually correlate it there. So biomedical people are awesome at having those little things that are out there to check for accuracy, not at the bedside, but obviously overall accuracy. Factors that affect the accuracy. Look at all this, right? So here's the big thing. You see everything here can easily cause an issue. So carboxyhemoglobin, methemoglobin, fetal hemoglobin, HbF, upstairs in the NICU, right? So that's why we're okay with running different saturations up there. Anemias, any type of vascular dye, so that they've had some sort of vascular dye for a procedure. If their bilirubin levels are up, of course, with your liver failure patients or in the NICU where their bilirubin levels are up, if they have darker skin pigmentation, if their perfusion's poor, which is very, very common, motion artifact, look at the PEDS unit, that's a very classic case there, nail polish, which nowadays, who knows, nail polish, and then ambient light, of course, can easily all play a factor into this. So this is just sort of a lesson that the pulse ox is not the end-all be-all currently. It is very important, and I'm glad that you guys carry one around with you, and I recommend it, right? Part of the fanny pack essentials, pulse ox, right? I should do a video on fanny pack essentials just to be hilarious. All right, pulse ox, always treat the patient, not the number, right? You see a weird number, look at the patient first and work your way back. Do they have altered mental status? Do they have poor hands? That's one thing I forgot to mention during the arterial line presentation, is when I would go into the patient's room with an arterial line, especially if they had a radial line, all right? Well, in fact, only if they had a radial or brachial line. I would go in there and I would touch the patient's hand, and I'd still have my glove on, but I would touch the patient's hand and I'd say, hello, Mr. or Miss So-and-so. I'm Derek with Respiratory Care, and I'm here to sort of look at your breathing machine and check how everything's going. And what I was really doing by touching their hand is trying to see how good of a perfusion they had to their hand. So I was trying to feel, is there an issue with the A-line? Is there an issue with their blood pressure together? Is there vasoconstriction? Is there hypothermia of their distal limbs where we were checking their pulse oxes? And so to the family members and to the patient, that seemed reassuring, doing that little hand gesture. But for me, as an assessment as a clinician, I was actually hiding that. I was actually assessing their perfusion to their fingers and toes and how accurate their pulse ox is. So look at the patient first, right? You see a weird number, look at the patient first. Work your way back from the patient. You never treat a monitor. You never treat a monitor. You will always look at your patient first. There was an MRI situation where we were taking a patient to MRI, and we're in the MRI, and the only thing that's accurate in the MRI was the end-tidal CO2. Everything else gets thrown off by the giant, powerful magnet thing. Even their EKG gets thrown off. So the only way you know that patient still has a pulse and a heart rate and is breathing is because end-tidal CO2 is uninterrupted. So that is the only accurate thing during an MRI currently until they figure out some other way to get accurate monitoring during those procedures. Even the special MRI EKG electrodes were not great. So like the only way we had a situation where a patient's end-tidal was suddenly cut off during the MRI, and they're like, oh, the end-tidal's off. And so I'm like, well, I'm going in there. So they stopped the procedure. I went in there, sure enough, they were disconnected, right? So it's one of those things we would have never caught had we not had end-tidal on that patient. So pulse oximetry, even an MRI, still not going to be nearly as accurate. So whatever machine or whatever monitoring you have, you always start with the patient, work back. Don't just assume it's machine error. Start with the patient and work your way back. It could very well be a machine error. It could very well be that the pulse ox just came off on the bed and the patient actually doesn't need any oxygen intervention, really. Okay, so enough of pulse ox. End-tidal CO2, this is a favorite category of mine. This is a very underutilized and very underrated area of respiratory care. This is a very important area for us to expand and to know what it means. Very few RTs out there understand not only what end-tidal CO2 means to them, but how to use it to benefit their patients more effectively. And so I'm going to preach end-tidal CO2 to you. So capnometry is the measurement of CO2 in respiratory gases. So that's a definition. Capnometer is the instrument you use to measure CO2. Capnography, so a graph, notice the keyword is graph in there, is a graph display of CO2. So this shows us changes with every breath. Capnography is a very valuable tool in critical care and emergency medicine. Very valuable tool. Into those graphs. Indications for end-tidal CO2. I obviously have a bias towards it, so I'm going to have a very light trigger to initiate it. But evaluation of CO2 in mechanically ventilated patients. This is a great way to see if their dead space issues being better or worse. It's also a great way to see if their hemodynamics are getting better or worse. It's also a great way to see if their ventilation is getting better or worse and their compliance getting better or worse. Like, it can give you a better total picture of this patient. So end-tidal CO2 in mechanically ventilated patients, I think, is an invaluable resource, and I think it's very important that you understand how important it is. You know what this means and what could cause it to be off. Monitoring severe pulmonary disease in response to treatment. Of course, we can see how well that they're responding to our therapeutic interventions. As far as intubation goes, we can see if it's esophageal versus tracheal. I love waveform capnography, right? I love capnography for intubation because then we know right away that they're in or not. We don't have to wait for some other issues to show up. Monitor the integrity of the vent circuit, artificial airway in the ventilator. We can actually see if the patient's extubated or intubated. It's pretty straightforward. Reflect CO2 elimination. We can see if their metabolic rates increasing or decreasing. We can see so much with how much their metabolic processes are going on. We could even do indirect telemetry where we can actually see what their metabolic rate is and if we're giving them enough nutrition for their metabolic rate or if we're overfeeding them and causing too much CO2 production. So there's a lot of value to this, especially with thermal injuries or burns. That's one of the things that we might see is we might do indirect telemetries on them because if they don't have those skin layers or tissues, they can easily lose a lot of energy or they can get cold or hot and it can change a lot of things. So monitor inhaled CO2 during therapeutic CO2 inhalation. So that's usually going to be more related to singulus and things like that. Further. Contraindications, there are none. There are no contraindications to end-tidal CO2. I'll repeat that again. No contraindications to end-tidal CO2, right? You remember you're treating the patient, not the number. So just like any other device, as much as I love this and how much more value it gives to what we're doing, you would start at your patient and work your way back. Precaution, people might misunderstand the numbers or the waveforms. They don't do their homework. They don't read. They don't understand. They don't master these patterns and waveforms. And that could be a big detriment because if they make a wrong interpretation, it could send you down a whole bad pathway. So I'm a big stressor on going over this information. Other things too, it can weigh down the vent circuit, especially on neonates that don't have a cuffed endotracheal tube. That could be an issue. It can weigh down the circuit a little bit there too. Depends if it's a side stream or a mainstream. These are standard of care in the operating room. Thank goodness. That's one of the big things on all those vents. They usually all have end-tidal CO2 monitoring. Most of our patients at Swedish it's Swedish. If they're on a ventilator, they have end-tidal, right? That was like one of our standard things. It is a very important thing to have. Assessment and outcome should reflect the patient's appearance. So that means if their blood pressure was low, and we gave them fluids, or we gave them a pressor, or we gave them PRBCs, we should see the end-tidal CO2 actually start to come back up because we had an increase in perfusion. Increased perfusion means there's more blood working its way back to the lungs, which means more CO2 can be eliminated. So that's something where their minute ventilation may not change, and yet their CO2 is actually climbing, but that's actually a good thing. That means their perfusion has improved. Or let's say we got a patient and their pulse pressure is starting to narrow, their heart rate's starting to get fast. So it looks like they're in cardiac failure, and now we see their end-tidal CO2 start to drop. Well, that's a definite sign that their perfusion is decreasing, so that's a sign that their heart failure is definitely getting worse and worse. And we might notice the end-tidal drop before a lot of other things happen, even before their saturations drop. So even in conscious sedations, end-tidal CO2 is extremely vital because that patient could easily, if they're given too much of that medicine, could easily hypoventilate, and their pulse ox will be just fine, but now they're getting acidotic, and you wouldn't know it unless you had end-tidal CO2 on. So, of course, I'm going to be a big thing here. So monitoring, ventilator parameters, and hemodynamics. Hemodynamics, huge thing, especially with critical care, especially with positive pressure ventilation. Hemodynamics and end-tidal CO2 are best friends there. Vent parameters there too, but I am a huge fan of what it means hemodynamics. Instrumentation, it's going to usually use infrared absorption, which is the most common. There's mass spectroscopy as well as a photoacoustic technology. So there's different types of technology that goes into it. And I think Gary White's Your Equipment Essentials book goes on that. There's two primary ways to measure it. There's either the side stream or the mainstream. that are out there. The mainstream is an inline analyzer. You see the picture of it down there. So you put this in line with the ventilator circuit, and it has this little narrowing that you then clip this probe onto, and it measures how much CO2 is going through there. Usually uses a laser, right? So the sensor's at the airway. It's a very fast response because it reads it at the airway. It doesn't have to pull it from the airway and suck it through a machine and then read it back in the machine. No, it reads it at the airway, and so we get a very fast response. So we don't have to sample flow it. So there's no sample flow also is a good advantage for neonates. So let's say we have a tidal volume on a neonate of 6 mils per kilo, and this kid is 1 kilo, right? So this kid's getting a tidal volume of 6 milliliters. Now let's say the sample rate is at, I don't know, 2 mLs per minute. So a very low sample rate overall, but now we're pulling 2 mLs of that 6 ml tidal volume away from that neonate. That's a big deal. That's a lot of their minute ventilation. So that's why something like this that doesn't use a sample flow could be an advantage to that patient population. Now, disadvantages, secretions. Right, there's a narrowing of the part where it clips onto, right? You see how it narrows. So that's Posey's law. You have that extreme narrowing, so you can have secretions, humidity. You have to calibrate it more frequently. It can be heavy, so it's more likely to extubate, especially on neonates. They're non-disposable, so you got a risk of infection transmission. And then they're only used on intubated patients. Now, there are some out there where you could use them on spontaneously breathing individuals, but we won't go there yet. But so you have some issues there, especially with raw and secretions and all that. Side stream, tube is placed between the patient circuit, and then air, like I said, that purge flow, or that it's sucking, like let's just say 2 mLs per minute or so into this measuring chamber, and then it's reading. So because it's measuring it back at the machine instead of at the airway, it's going to be a lag in end-tidal waveform. So you're going to see a little bit of a delay compared to what's the ventilator. So the big advantages is there's no bulky sensor that goes in line with their airway. We can measure things in the airway like nitric and all that stuff. We have a disposable sample line, so that's not as much of an infection risk as there is with inline. So we can use it with non-intubated patients, which is most common out there. We have the end-tidal nasal cannulas. I believe even the oxymasks have end-tidal capabilities as well out there. Disadvantages, secretions can block that little sample line. You can get water in there. You need to remove excess water from that trap that purges gas from the line, because remember there's heated humidity going on here. You have to calibrate them. Slow response time, we talked about that because it measures it back at the machine versus at the patient. And then, of course, more in your pediatric neonate population, that sample flow may decrease tidal volume and hypo the patient. Interpretation, here's sections 1 through 4. Section 1 is where there's no CO2, so the CO2 is at 0. The origination of exhalation, so this is the dead space that's in your trachea and main stem, right? So there's none. As the patient further exhales, you're going to see the waveform start to go up. So now we got more dead space going on. So now we're in the segmental, subsegmental bronchi, right? We have some more of that CO2 mixed gas that's coming out. Phase 3 is where we see the plateau or the alveolar phase. Very important that phase 3 is flat. It's very important that it's plateaued. If it is not plateaued, if you do not see a flat phase 3, that is a sign that there's poor alveolar ventilation. I will repeat that again. If phase 3 is not a plateau, that means the alveoli are not being ventilated. So severe bronchospasm, you'll see a shark fin waveform. You won't see a plateau, and that's a sign of very poor alveolar ventilation. So you need to see an alveolar plateau. You need to see that plateau, and at the end of the plateau is where the end-tidal CO2 measurement is taken. So the very end of it, and we'll look at the waveform here in a second. So, and then finally phase 4 is a rapid decrease in the CO2 patient, decrease in CO2, and that means the patient is inhaling, right? So that means the gas is being moved the opposite direction. All right, end-tidal CO2 waveforms. So in healthy individuals, the end-tidal CO2 averages about 1 to 5 millimeters of mercury lower than the ABG. So that's assuming there's no dead space issue. So if you were to draw blood gas and the PA CO2 on the ABG was, let's say, 40. So we got a PA CO2 of 40 millimeters of mercury, and the patient's on end-tidal CO2. So it should either be about 35 or so, 35 to 40 on the end-tidal CO2. It's going to be lower because remember that whole FRC thing. You got gas that stays in the lungs at end exhalation, so therefore the end-tidal CO2 is going to be slightly lower than the actual PA CO2. Right? So if you got someone with severe air trapping, or if you got someone with a lot of dead space issue, their end-tidal CO2 may actually be quite a bit lower than their PA CO2. Let's say we got a patient on a ventilator and there's too much pressure and we're over-distending the alveoli, we're over-distending the respiratory zone. Well, it's causing the capillaries on the outside of the alveoli to be squished, which means there's less blood flow, which means the end-tidal CO2 is going to look low. But when we draw a blood gas, their PA CO2 is actually going to be high. So the further discrepancy you see between end-tidal and arterial CO2, the more dead space you have. That means you created either alveolar dead space with something like hyperinflation, or anatomic dead space has been created, right? So that can be a sign of alveolar destruction, airway destruction, burn victims, things like that you will see here. So it should be within about 5 millimeters of mercury. Remember, it should be a little bit lower than end-tidal CO2. If you see a big discrepancy, that's one of the big issues. That's where I told you guys I had that girl that had massive amounts of PEs, and her end-tidal CO2 was like 19, and I drew her blood gas, and she was, breathing, she was tachypnic, tachycardic. I drew a blood gas. Her end-tidal was 19 at the time of the blood gas. I drew the blood gas, and her CO2 was at 40. So her end-tidal was less than half of what her PA CO2 was. That's not normal. That's a huge dead space process. And her issue was she threw blood clots, right? So that's something that I like to look at there. Dead space have we looked at? So the waveforms, if they're hypoventilating, then you'll start to see that progressive increase in the waveforms. Expect me to test you on the waveforms. Hyperventilation, you'll see the waveforms in a decreasing ventilation, decreasing pattern, because remember we're getting rid of more CO2, so the CO2 peaks are going to get smaller. High CO2, the CO2 peaks are going to get taller. They're going to progress higher and higher. If there's a leak in the ET tube or something like that, or the cuffs like leaking on the ET tube, circuit leak, someone left a Ballard, flush line open, something like that happen, you're going to see funky waveforms because air is escaping. So your CO2 level place there. Abnormal waveforms, if there's a disconnect, you usually see it go down to almost nothing. If there's a disconnect, so you'll know the patient's extubated. So waveforms, pay close attention to the waveforms. That's a big indicator of what's going on. The shark fin thing, I need to bring some of those in for you guys. But you can Google image shark fin capnography, and that's a classic sign of air trapping or auto PEEP, especially with your asthma or emphysema patients. It's a big bad sign. So also know if they're on positive pressure ventilation and we make a change and you see their end-tidal CO2 drop and you've somehow increased the amount of pressure or volume that the patient's getting, that could be a bad sign, right? That could be a bad sign if their end-tidal CO2 is dropped after you make a ventilator change that increases settings, because you could be causing over-distension. You could be causing an alveolar dead space issue. Not good. That's trauma. That's ventilator-induced lung injury. So please, please watch your end-tidal CO2 when you have these patients on mechanical ventilation. Understand that as you see it drop and the gradient increase between end-tidal and PA CO2, you're actually doing these patients harm. So you should see them close to each other. If you do not, there's a dead space process. and it could be a sign that you might have to actually decrease your settings to get more optimal patient care out of this situation, because their saturations will drop as well, because now there's more CO2 being retained in their system because there's less blood actually getting rid of CO2. It's also a good sign of hemodynamics, right? You got a patient that's in severe sepsis, put them on end-tidal CO2 even if they're not intubated yet, because that's a sign of perfusion, and as the end-tidal drops, that's a sign that they're getting worse, and that's a sign that we may need to go start looking at things that would help their hemodynamics more effectively. So invaluable tool, that end-tidal CO2. You know how important it is. You know what it means. I encourage you to continue to burn that into your technology, into your brain, into your practice when you're out there. I dare you to use end-tidal and know what it means out there. There's a lot of people that undervalue that. Transcutaneous monitors, way more common in neonatal pediatric patients than adults. There was a study by Respiratory Care Journal, of course, and it's the same study that same journal article that I posted earlier, or that I talked about earlier, where it looked at transcutaneous monitors, and if someone has poor hemodynamics or low blood pressure, then it's not going to be nearly as accurate as if someone had a normal blood pressure. Well, the patient population where you'd want to do continuous oxygen monitoring and continuous CO2 monitoring would be one that's hypovolemic, one that needs it the most. And so it's not going to be near as accurate as a blood gas. So even with the transcutaneous monitor, which looks at continuous PO2 and continuous CO2, it's not going to be near as accurate in people that have poor hemodynamics, that are very low or hypotensive. So this looks at how much oxygen and how much CO2 is in the blood. So what we're going to do is we're going to place this sort of sensor that heats the blood on the skin, that sort of heats the blood to arterialize it. And you're usually looking more about at the CO2 level here than the PO2 level, because it does a hypermetabolic rate. So it's usually around 42 to 44 degrees centigrade, and that's usually a board exam question. 42 to 44 degrees centigrade, so it heats up the skin, and so what happens to your oxygen levels as you have more metabolism? Well, oxygen gets consumed, and therefore the PO2 on this is not going to be as accurate as following the CO2 on this. So usually we're following more the CO2 than the PO2. So it heats the blood up. It depends on the perfusion status, how accurate it is, right? That's why the CO2 is more reliable. Remember, it's a hypermetabolic situation, but that means we have vasodilation, which means we get more perfusion to that area, which means we can actually get a better look at how much CO2 is actually going on in the bloodstream. More common in the pediatric and neonatal side of things than the adult side of things, because the adult side of things usually don't have as much accuracy.